Thank you, Jay. Thank you. That was a long introduction. You could have summarized it. He's old and he has a bad back, so he's going to like hobble around. But thank you for the invitation. I've had the privilege of serving on the Peterson board for the past several years, and it is a phenomenal organization. And thank you, Coach. Coach Peterson's back in the back. And thank you to all the sponsors who made this event possible. So I wanted to speak today. Normally I speak about, research and what's going on in research, and I thought we'd take a break from that today. Vanderbilt has a Parkinson's conference coming up in the fall, and we'll talk about research then. But I thought we should talk about some of the old things, what people are taking. So many times people are taking medicines and they don't know why, and they don't know, what's out there and what's available. And Dr. Lazarus gave a great introduction to this, so let me just go through this for you. So as far as conflicts of interest, I have worked with AbbVie Pharmaceuticals in the past as a consultant several years ago. I currently don't, and I am involved in a number of clinical trials, but we're in general only going to talk about therapies that are currently FDA approved. So the general treatment, we talk about treating the motor symptoms of Parkinson's disease. The motor symptoms of Parkinson's disease come from premature loss of cells in the brain that make a chemical called dopamine. And the general idea of symptomatically treating Parkinson's disease is trying to replace that deficiency. So in people without Parkinson's disease, our brains are secreting dopamine at a constant rate throughout our waking hours. It goes down a little bit as we sleep, but during our waking hours, regardless if we're sitting in the recliner, watching the football game, or we're working out hard at Rocksteady Boxing or whatever, the amount of dopamine our brain is secreting is just constant throughout the day. So what the therapies are trying to imitate is that continuous dopaminergic stimulation throughout the day. And because of that, there are many kind of long-acting oral medications available to try to smooth that out. And in general, at least when you talk about levodopa, when you take levodopa, your body is rapidly trying to get rid of it. Just like it tries to get rid of every medicine, but levodopa itself has many pathways that the body uses to get rid of it and clear dopamine. And the long-acting formulations of levodopa, they work, but they have some, variability from person to person. Dr. Lazarus said that taking immediate release levodopa, the kind of typical levodopa that people take, only about 15% of what is orally taken makes it to the brain. And with the controlled release formulations, it's generally even less than that. So there's that to deal with. And that's an important thing. I love support groups, but one of the things that people always do is they share what medicines they're on. In Parkinson's disease, there is only a very rough correlation between how much levodopa people take orally and how severe their symptoms are. So depending on how well they absorb it, how fast they metabolize it, there are some people who have relatively mild symptoms that take very large doses of levodopa, and other people who have relatively severe symptoms of Parkinson's disease who take small doses. So there's a lot of variability. And the problems, for patients and for their doctors who take care of them is that Parkinson's disease is probably Parkinson's diseases. Depending on how you want to split them up, some people talk about young onset and what used to be called old onset, but now that I'm old, I call typical onset. And so typical onset Parkinson, young onset, there's tremor predominant Parkinson's, akinetic rigid Parkinson's. There's, Parkinson's disease that has comorbidities that don't allow some medications to be taken. There are variations in insurance coverage from patient to patient on what they can take. Drug interactions, sensitivity. So it's kind of like, which haircut looks best on, not the same haircut looks best on everybody, and not the haircut that looked good on you when you were 20 doesn't look good on you when you're 65, and, it's everyone is different. Thank goodness. And even among an individual, we change over time, so a medication that might work well early in the disease might not work well later in the disease. So this is what happens. So early in the disease, you still have a fair amount of surviving nerve cells that make dopamine, and so you can take a dose of levodopa, and the levodopa that makes it to the brain is converted to dopamine. It's stored in those surviving cells and then is slowly released over time. Uh-oh, did I turn my slides on? Okay, good. Slowly released over time, so you get this longer duration response. As the disease progresses and you lose more of those dopamine-producing neurons, the dose comes in, it goes higher because it's no longer stored, and then it goes down quicker because it's out in the brain and susceptible to metabolism. So the duration of response to a single dose of medication shortens as the disease progresses, and the therapeutic window, which is the level that you're trying to maintain in the brain, that provides symptomatic benefit without side effects, narrows. So it becomes harder and harder to keep the level of dopamine in that sweet spot. So carbidopa, levodopa, which is actually two medicines, carbidopa and levodopa in one pill, is the mainstay therapy for the treatment of Parkinson's disease. Essentially every patient with Parkinson's disease takes it, with very, very rare exceptions. The carbidopa is in there to block conversion of levodopa to dopamine in the bloodstream. Dopamine, if it's converted, if levodopa is converted to dopamine before it makes it to the brain, the dopamine can't cross the blood-brain barrier, and so you don't get any effect out of it. And so carbidopa is in there to block that conversion. Also, dopamine in the bloodstream causes nausea, and so the carbidopa prevents nausea. Levodopa is a naturally occurring amino acid, and like dietary amino acids, it's absorbed in the small intestine, and individuals can only absorb so much amino acid at one time, and there is a lot of individual variation from person to person on the amount of amino acid that they can absorb at one time. So in a minority of people, protein interferes with absorption of levodopa. Normally patients recognize that and say, when I eat a big protein meal, my levodopa doesn't work as well. But it's confusing to patients, it's confusing to pharmacists. You know, the pharmacists put those little stickers on your medicine bottle, you know, take with food, take without food. I've actually seen 2 bottles of levodopa with opposite stickers on them. If you take it with food, it's less likely to cause nausea. If you take it without food, it's a little more likely to be fully absorbed. And I just tell people to take it at regular intervals unless they really notice something. The side effects of getting too much dopamine or too much stimulation of dopamine receptors is the same for levodopa and the dopamine agonists that we'll talk about in a minute. But it's nausea, low blood pressure, particularly when you stand up, sleepiness sometimes, vivid dreaming or nightmares, hallucinations, and impulsivity. And what we mean by impulsivity is doing something that you can't stop. You know, whether it's shopping or eating or stamp collecting or, you know, buying things, sexual activity, whatever you're doing that you can't stop, and that's impulsivity. Levodopa is available in a bunch of different formulations. It is available in, you know, what is now referred to as immediate release, which is the standard carbidopa-levodopa tablet that many people take. There is a dissolvable version of that for people who have a hard time swallowing. There are sustained release formulations like Crexont and Rotari, which are little beads of carbidopa-levodopa that dissolve at different times to have a more kind of constant stimulation. There is a carbidopa-levodopa paste that is given sometimes by infusion through a gastric tube to the jejunum. There's an inhaled version of levodopa, like an asthma inhaler that's used for people who have unpredictable off periods. And there's a subcutaneous infusion of levodopa for treatment of motor fluctuations. So a lot of different formulations of levodopa. This is, this was the only picture I had of the stomach. It is a duopa pump, which is the carbidopa-levodopa gel, which is used much less now than it used to be used, now that there are subcutaneous pumps for levodopa and apomorphine. But you can see that the tube, although it enters the stomach, it travels down through the intestine to a section of intestine called the jejunum, which is where levodopa is actually absorbed. And like Dr. Lazar showed, you know, some of the variation in response to levodopa has to do with the fact that the stomach doesn't always empty at the same time, and if the formulation stays in the stomach, it's not absorbed. So if you can't go to the pharmacy now. When I go to the pharmacy to pick up my cholesterol medicine, I can't get it without being handed 10 pages of information that tells me that I shouldn't take it or I'll die. And nowhere in that information does it say that lowering my cholesterol reduces my risk of heart attack and stroke. So in the information about levodopa, there is a mention of melanoma. This has been studied pretty closely, and it's very hard to find any increased risk of melanoma in patients with Parkinson's disease. It was reported initially, and it is now thought that much of that earlier report was due to shared risk factors. And what we mean by that is that we do know that men are more likely to get Parkinson's disease than women. We do know that people who had lived much of their life rurally are more likely to get Parkinson's disease than those who lived in an urban environment. And we do know that it looks like in many studies that fair-skinned people are more likely to get Parkinson's disease than dark-skinned people. And so it just so turns out that fair men who live in rural areas are also the highest at risk for melanoma due to sun exposure. So we think it's probably shared risk. We do, recommend to people not to ignore, suspicious lesions on their skin, whether they have Parkinson's disease or not. There was also kind of an idea many years ago, and it's hung around in some places on the internet, that levodopa itself was toxic. This came from pouring like industrial amounts on cell cultures, but in humans there is absolutely no evidence that levodopa is toxic. Like I said, it is a naturally occurring amino acids. You can feed pounds and pounds of it to animals, and there's no damage in the brain, and there's no damage in the brain of people who take levodopa for other conditions other than Parkinson's disease. So there's no evidence that it speeds progression of Parkinson's disease, and there's very good evidence that it extends lifespan in people without Parkinson's disease. I think it's important to remember that before the advent of levodopa, Parkinson's disease patients generally had a lifespan in the 8 to 12 year range. So it was clearly a terminal illness, and all of us know that that's greatly extended now. So that's kind of levodopa. There are then this class of what are referred to as dopamine agonists. So dopamine agonists stimulate the same receptors in the brain that dopamine does, but they're not dopamine. So you can think of them as artificial dopamine. And they have an advantage over levodopa in that they generally have a longer duration of action than levodopa. Their absorption is not affected by protein. They have the exact same potential side effects as levodopa, and as is many of the cases in medicine, because they're longer acting and because they're not affected by protein, they tend to have more frequent side effects than levodopa. So there's no free lunch. So I think there's pretty good evidence that the low blood pressure, the nausea, hallucinations, those kind of things are more likely to occur with dopamine agonists than levodopa. There are currently 4 dopamine agonists on the market: ropinirole, which is Requip; pramipexole, which is Mirapex, are probably the oldest 2, and they're available in long-acting formulations. And then rotigotine, or Nupro, which is a dopamine agonist patch. And you would think that a patch would be perfect. A patch would be continuous over 24 hours. And it is, but you can put the same patch on different parts of your body, and depending on skin thickness, get a different dose. So even with patches, there's some variability from dose to dose. And then apomorphine, which Dr. Lazarus talked about, is not available orally, but it's available by subcutaneous injection. So both as a single pen, like an EpiPen, where to be used for unpredictable off periods. So patient would be out at a restaurant and unpredictably turn off, and it wasn't time for their next dose of medication. They could take an injection of apomorphine and within a few minutes turn back on. And that formulation is sold as Apoquin. And then that same liquid apomorphine is available in the pump that Dr. Lazarus talked about. And the pump has the advantage that we talked about at the very first slide of being continuous, and the continuous stimulation is what we are going for. I don't expect you to memorize this. I expect our fellows to memorize this, but this is a reminder that if you take levodopa, which is the L-dopa up there at the top, the second you take it, your body's trying to get rid of it. Not because it's poison, but it just tries to get rid of everything you give it, whether it's a hamburger or levodopa. So the biggest pathway is to dopamine through an enzyme there in red, amino acid decarboxylase, and that is the step that carbidopa blocks. There's this other step that we're going to talk about in a minute, the COMT step that converts levodopa to 3-O-methyl-dopa over there. But what we wanted to do, that blue line is the blood-brain barrier. We wanted to cross that and get converted to dopamine. And some of it does. Unfortunately, the minute it does, this enzyme down here converts it to homophenoic acid. So that's what we're fighting. And there is a strategy in Parkinson's disease treatment where instead of, or in addition to, using a long-acting formulation of levodopa, we use another medication to block the metabolism of it, so that the dopamine that you do take hangs around longer, so you get more kind of miles per gallon out of it. And so the monoamine oxidase inhibitors, of which there are 3, selegiline, rasagiline, and safinamide, block the metabolism of dopamine to homophenoic acid. And so it makes a dose of levodopa last longer. So if you're wearing off between doses, it reduces some of that. The main potential side effect of the monoamine oxidase inhibitors it is very similar in many ways to increasing the dose of levodopa. It's a little different in that the peak doesn't go higher, but it hangs around a little longer. But things like dyskinesia, things like low blood pressure and nausea, so it can exacerbate the side effects of levodopa. So both the good and the bad of levodopa. It also, many of the oral antidepressant medications work by increasing brain levels of serotonin, and monoamine oxidase inhibitors also inhibit the metabolism of serotonin. So taking a monoamine oxidase inhibitor with your antidepressant is like taking a little larger dose of that. There's not really been many reported side effects of that. It's like a 15 to 20% increase in the dose, and so it's probably a better thing for most people than a side effect. So that's blocking this step down here, the monoamine oxidase inhibitors. And then there is another set of medicines, the COMT inhibitors. They block that other pathway. So they block the metabolism of levodopa before it makes it to the brain, again allowing levodopa to work longer. And there are 3 COMT inhibitors on the market: entacapone, which is the most common because it's gone generic, opicapone, which is a long-acting form, and talcapone, which is an older formulation. Again, these are like increasing the dose of levodopa by 20-25%, and so can have the same side effects as increasing the dose of levodopa. They have less influence on the antidepressants than the monoamine oxidase inhibitors. So carbidopa blocks that first step up there. The COMT inhibitors block that second step, and the monoamine oxidase inhibitors block that bottom step. And so those are, therapies that are used to try to help, levodopa work better, to try to avoid. Now, getting back to this slide, you'll see at the very top of it, there's those 2 hashed lines, the threshold response and the dyskinesia threshold. So it's common for people who are under-medicated to take a dose of levodopa, and as the level rises, it'll reach a threshold and they're like, okay, now it's working. And for many people, particularly with, moderate to advanced disease, they actually kind of feel it kick in, and that's where the on-off kind of terminology comes from. So once you cross that threshold, you're on. If it continues to rise and it gets high enough, you can actually get involuntary movements from levodopa, and those are termed dyskinesia. And those, and instead of being tremor, which is this rhythmic movement, are these random movements that kind of look like fidgetiness. So you try to work that therapeutic window between there to be on without dyskinesia. So these are the kind of motor fluctuations that we talk about. Wearing off is where the level goes down and you turn off between doses. And generally people who get less than a 4-hour interval between doses are referred to as having wearing off between doses. You have peak dose dyskinesia, so that when you take a dose of levodopa, 20 to 40 minutes after you take it, most of the time it peaks, and that is the time when you're most susceptible to have the involuntary movements from having too high a dopamine level. There's end-of-dose dystonia. Dystonia is an involuntary twisting move that's sustained at the peak. It's kind of like a cramp. Most commonly seen probably early in the morning after you've been off your medications all night long. You might have cramping in your toes or turning of your feet inward, and that's due to a low levodopa dose. Diphasic dyskinesia, where you just kind of fluctuate between on and too much dyskinesia, on and too much dyskinesia, and then random on-off, where I think most people with moderate to severe Parkinson's disease know that they've had times when their medicine just doesn't work, and for no apparent reason, and then it suddenly kicks in. So Dr. Lazarus talked about the treatments for wearing off. It's exactly what you would think about. It's more frequent, smaller doses. It's adding these medications to try to make levodopa last longer, adding a dopamine agonist as an adjunct, whether it's an oral or through a pump, using a pump for levodopa. Those are the kind of things that are used for wearing off. There are two medicines on there, amantadine and estradefylline, that we haven't talked about yet, and we'll talk about that. This is estradefylline, or Nuriaz. Dr. Lazarus mentioned it briefly. That top molecule there, you have to forgive me, remember I had that PA in chemistry, so I still like medicinal chemistry. That top molecule is estradefylline, Nuriaz. The bottom one is something that many of you took this morning. Anybody know? Caffeine. So this is caffeine. That's Nuriaz. I hope you see that they share a structure. They also have a similar effect. They block a chemical called adenosine. So estradefylline is kind of a long-acting caffeine-like medication. It turns out that there are adenosine receptors in the brain that modulate dopamine function, and in some people, stimulating those helps their Parkinson's symptoms. It's a different, totally different mechanism than the dopamine thing, and so it's a medicine that doesn't cause low blood pressure. So people have low blood pressure, we sometimes use that. It doesn't cause sleepiness. It's like caffeine. We kind of wakes you up. We sometimes tell patients if they're interested in trying it, they can see if caffeine is helpful. If caffeine is helpful, it's likely that Nuriaz would be helpful. And then dyskinesia. So treatment of dyskinesias. again, you're trying to keep that level in that therapeutic window. So many of the treatments for wearing off are also treatments for dyskinesia. More frequent, smaller doses, pumps, dopamine agonists. Botulinum toxin is sometimes used for painful dystonia. You inject it into the muscles that cramp, and it's used. And then amantadine. Amantadine has a separate approval just for treatment of dyskinesia. So amantadine holds the record as the first medication officially FDA approved for treatment of Parkinson's disease. So it was approved even before levodopa. It was developed to treat influenza, and prior to the advent of levodopa, many people with Parkinson's disease ended up in nursing homes, and nursing homes commonly prophylacted their population against influenza with amantadine, and they just noticed that the people with Parkinson's disease got better, and it became a Parkinson's medicine. So the power of observation. It is a mild dopamine agonist, and it also blocks a chemical in the brain called glutamate, and it's that blocking of glutamate that we think gives it its ability to decrease dyskinesia. It is available in long-acting formulations and regular formulations, and it has a mild effect. It has a unique side effect in that it can cause ankle swelling and this kind of unique purple modeling of the leg called livedo reticularis. And so we talked a lot about medicine. What about deep brain stimulation? I will say things about deep brain stimulation. Number one, it's not new. It's old. It's been around how many years? 25 years. 25 years. So it's been around. It's improved from what it was been around. It is a constant therapy because the electricity is on all the time, and it has many of the same benefits as the pump medications. And one thing to realize about it is in general, except for medication-resistant tremor, so there are some people with Parkinson's disease where the levodopa doesn't adequately treat their tremor. But except for tremor, deep brain stimulation doesn't treat any symptom that levodopa doesn't treat. It's just more constant. And like the apomorphine pump, it's used in addition to levodopa. So you don't necessarily stop levodopa. Like apomorphine, you often go down on levodopa, but it does not replace levodopa. So it's still a very potent therapy because it is continuous and adjustable. It's very similar in many ways to a pump. And then finally, what may be coming, and like I said, we'll cover more of this in the Vanderbilt lecture in the fall, but gabapentin, which I think this is the way it's said that, is the kind of newest medication in the pipeline. It is a once-a-day dopamine agonist, and it is unique among the existing agonists in that it stimulates the various dopamine receptors in a different way that's hoped to have fewer side effects than the current dopamine agonist. It filed for NDA, which is a new drug application, in September of 25. And what that meant was the company, gave the FDA all the information in September 2025, and you could ask, well, what's up? And I would say that if you look at the FDA for the past 120 years, the FDA has generally had one head for each president, and they've all been physicians and pharmacologists. And for the current administration, we've had 3. They've all been lawyers, so what could go wrong? But hopefully we won't put physicians in charge of the judicial system, but maybe Tabadon will eventually make it to the market. And then there are stem cell therapies currently in phase 3 trials that I've talked about before, and they have been enrolling faster than expected. And monoclonal antibodies targeting alpha-synuclein are also in phase 3 trials. We talked about last year, I think, phase 3 trials are the trials that are done, the final trials that is done before a therapy is submitted to the FDA for approval. So both of those trials are recruiting faster than predicted. So hopes are there. So with that, I'll be happy to answer any questions. I may sit down though, because of my back.
Where's the EPA on the drug?
You'd have to ask the FDA. They're, like I said, it's, I can tell you that for the one that is already filed, the NDA, the top one, it's been there longer than traditionally it would have before. The FDA can say no or yes, they just haven't said anything. So it's been longer than traditionally it used to be.
Yes, we know about deep brain stimulation, but there's something called adaptive deep brain stimulation that are in trials in this country and overseas to help walking. Do you have any information on those?
So there is, so adaptive DBS is actually FDA approved in the United States. Adaptive DBS is where the stimulator is actually recording from the brain, and based on what those recordings show, it changes its settings. It's not so much targeted specifically for gait as it is wearing off or dyskinesia. So if it's sensed like dyskinesia, it might turn itself down. If it's sensed, that you are wearing off, it might turn itself up. There are also trials in effect of not adaptive DBS, but what I think is sometimes called receptive DBS or responsive DBS, where a patient would have like a button that they could press if they had freezing of gait, and the DBS would abruptly change to try to break a freezing of gait. But that's a little different strategy where the patient would trigger it manually rather than adaptive where the brain is triggering it.
So can you explain about the antibody against the alpha-synuclein, so that
Sure.
you keep it from?
Sure. So there is a protein called alpha-synuclein, which apparently we all have some of that we don't know what the use of is. But it accumulates in the nerve cells of patients with Parkinson's disease. And there is a theory that it leads to the death of those nerve cells, and that the accumulation is in and of itself toxic. And so using antibodies against that protein, you can try to clear the brain of alpha-synuclein. In the same way, and it's a very common strategy. First of all, I would say that antibodies are widely used in medicine now. They're not just to treat infection, they're to have like specific actions. And so, there's an antibody to treat migraine headache, there's an antibody to lower cholesterol. And so these would be antibodies to get rid of alpha-synuclein. They are monthly infusions. similar to the monthly infusions against a protein called amyloid. They're FDA approved to treat Alzheimer's disease now. And so, yeah, the hope is that clearing the brain or partially of alpha-synuclein would actually slow the progression of disease. Alpha-synuclein is also deposited in the skin of the vast majority of people with Parkinson's disease, and so skin biopsy looking for alpha-synuclein is now used as a diagnostic tool for, early Parkinson's disease. Do I have Parkinson's disease? We sometimes do skin biopsy if the clinical picture is confusing. That helps sometimes. Did that explain it? Okay. Yes.
On these stem cells therapy, how are they deposited in the body?
So the stem cell injections that are being done under, the trials for Parkinson's disease are, the other name for stem cells are precursor cells. These are precursor cells they're basically nerve cells that make dopamine. And so they are injected into the brain near this place where dopamine cells are dying in Parkinson's disease. And they could provide benefit in two ways. One way is they could act as kind of dumb dopamine factories and just make dopamine. That might be helpful, that might be problematic if they make too much. The hope is that they will not only make dopamine, but that they will connect to the existing neurons and be under control of those neurons and act more like your natural dopamine cells and not only make dopamine, but make the right amount. The cells are injected directly into the brain, so there is a risk of the procedure, causing stroke at the time of the procedure. So it is a relatively invasive cell transplant. Well, yes. So the question was about the relationship between levodopa and cognitive and hallucinations. Okay. So as Parkinson's disease progresses, many people, in addition to the motor symptoms, develop non-motor symptoms. And one of the common motor symptom is cognitive difficulty. The most common cognitive difficulty is in verbal fluency, how well you can think of words, or executive function, which is multitasking. And people with cognitive difficulty in Parkinson's disease are more susceptible to hallucinations as a side effect of the Parkinson's medications. There's also a cognitive complaint that many patients with Parkinson's disease, even early in the disease, complain of, which is like they're just not as quick as they used to be. So it used to be called bradyphrenia, slow thought. And levodopa actually helps bradyphrenia. So there's that. The other, I'm not sure exactly, so there's that part of your question. There is also a condition called diffuse Lewy body disease, where people develop memory difficulty and hallucinations, and then develop Parkinsonism. The Lewy bodies in that condition start in the cortex and spread to the brainstem. In Parkinson's disease with dementia, they start in the brainstem and spread to the cortex. But that's the other kind of relationship. Cognitive decline is a risk factor for hallucinations. Yes. Yes.
At a Parkinson's Foundation presentation a couple of years ago, we heard about a study at University of Kentucky where they were grafting cells along with the DBS, and it seemed promising. Could you tell us a little bit about that, if you know anything?
Well, that is a single site study. I do know about that study. It's very interesting. Those grafts, those were nerve grafts, and I think the group that was doing it thought of less of that being a stem cell transplant and more of the nerves being a source of nerve growth factor, which is these proteins that are involved in survival of brain cells in general. And so that they thought that the increased nerve growth factor from the peripheral nerve transplant into the brain would slow the progression of Parkinson's disease. And one of the challenges in those studies is that in order to show that Parkinson's disease is slowed, the study has to be several years long. And so I think they're doing a very careful job of it, and I applaud their work, but I don't know of any additional findings. Yes, sir.
Could you tell me about the diagnostic methods to determine whether it's MSAP or Parkinson's and how accurate the reliability of those results?
Sure. So the question is about the diagnosis of Parkinson's disease versus a condition called MSAP, or multiple systems atrophy, Parkinson's type. In both conditions, you lose neurons in the striatum. And in both conditions, you have Lewy bodies. So one of the downsides of skin biopsy is that it's positive. It's positive for Parkinson's disease. It's positive for MSA, which also has synuclein, and it's positive for diffuse Lewy body disease, which all has lucid. So you can't separate MSAP from Parkinson's disease with skin biopsy. The other kind of tool that is sometimes used is a DAT scan, which is a radionucleotide scan, looking at the dopamine transporter protein in the brain. And unfortunately, since both conditions lose dopamine, the DAT scan is positive in MSAP. MSAP usually has prominent autonomic dysfunction relatively early, so relatively severe orthostatic hypotension, maybe trouble with sweating and temperature, maybe erectile dysfunction, those kind of things. It's a hard differential to make, particularly early on, between Parkinson's disease and MSAP. MSAP is less likely to have tremor, but there is akinetic rigid Parkinson's disease, and both akinetic rigid Parkinson's disease and MSAP require higher doses of levodopa. So, yeah, it's a very hard differential to make. I will say that unfortunately we're at a time where if I knew for sure that this person had Parkinson's disease and this person had MSAP, they would get the same symptomatic therapies. They would both get dopaminergic medication for their Parkinsonism. They would both get symptomatic treatment of their autonomic dysfunction if they had autonomic dysfunction. So right now there's not a specific therapy for either one. There are clinical trials for MSA, and so if that diagnosis was being entertained entertained, they could be referred there, and there's some additional, like, experimental ways to try to separate the two for those trials. Yeah, but usually by the time either one would be a candidate for deep brain stimulation, you would know whether somebody had Parkinson's disease or MSA, because it's difficult to tell the two apart early in the disease. It's relatively easy late in the disease, and so by the time that came around, it would be, yes, but you're right. MSA is not responsive to DBS, and Parkinson's is, yes. Yes. And you think I know it now and I didn't know it? Okay.
The 2016 Georgetown study that used a chemotherapy drug that had very promising results, I know that has not been replicated in the United States, but are you aware if it's being done anyplace else in the world?
Well, there was, the Parkinson's study group did a larger study and was unable to replicate it. But I don't know of